Good morning, everyone. We warmly welcome you to the 6th Undergraduate Research Symposium of the Faculty of Medicine and Allied Sciences. We warmly welcome you to the 6th Undergraduate Research Symposium of the Faculty of Medicine and Allied Sciences. We warmly welcome you to the 6th Undergraduate Research Symposium of the Faculty of Medicine and Allied Sciences. We warmly welcome you to the 6th Undergraduate Research Symposium of the Faculty of Medicine and Allied Sciences. We warmly welcome you to the 6th 15 groups out of that will present their poster presentation during the morning session. Now, I would like to invite Dr. Janith Varmasekara, Head of the Community Medicine Department, to deliver the welcome speech.
Good morning, ladies and gentlemen. As the head of the Department of Community Medicine and as the coordinating department of Research in Medicine module for the undergraduates of Faculty of Medicine and Allied Sciences, Rajaratna University of Sri Lanka, it's a glad moment because today we are commencing the 6th Undergraduate Research Symposium of Faculty of Medicine and Allied Sciences, Rajaratna University of Sri Lanka. My duty here is to welcome you all. Because of that, I'm not going to talk much. First, I would like to welcome the Dean of Faculty of Medicine and Allied Sciences, Rajaratna University of Sri Lanka, Dr. Janaka Pushpakumara, who is one of the key persons behind the success of Research in Medicine module as well as this research symposium. Next, I would like to welcome the panel of experts who are joining online today and who are sharing their valuable time despite their busy schedules. Dr. Damitha Gunawardana, Dr. Ishanka Thalagala, Dr. Manoja Pereira, Dr. Samiti Navaratna, and Professor Champaratna Tunga. Thank you very much for joining us today and giving your valuable time despite your busy schedules. I would like to welcome all the academic staff members. Without them, we will not be able to coordinate this Research in Medicine module because they have been here for guiding our students, supervising our students during the last 1.5 year period. Also, I would like to welcome all the non-academic staff members who are contributing and supporting the research projects in Faculty of Medicine and Allied Sciences. At last but not least, I would like to welcome all my dear students. Today, they are students, but one day, with the experiences that they are gaining during this module, they will be contributing to the field of science as different experts. Thank you very much. I hope that you will enjoy the research symposium today. Thank you.
Thank you, sir. Now, we will listen to a special message by Dr. Janaka Pushpakumara, Dean of the Faculty of Medicine and Allied Sciences, Rajaratna University of Sri Lanka.
Esteemed evaluators, faculty members, supervisors, and our aspiring young researchers. It is with immense pride and great pleasure that I stand before you today at the Student Research Symposium of the Faculty of Medicine and Allied Sciences, Rajaratna University of Sri Lanka. Today marks a significant milestone in the academic journey of our 2018-19 batch medical students, as they present the culmination of months and sometimes years of hard work, dedication, and scientific inquiry. The inclusion of 8-credit research component in our MBBS curriculum is not just a requirement. It is a vital part of shaping well-rounded medical professionals. This component provides our students with the opportunity to develop essential skills beyond the clinical practice. It enables them to critically evaluate scientific evidence, adopt methodological approach to problem solving, and contribute to ever-expanding body of medical knowledge. In an era where evidence-based practice is the cornerstone of quality healthcare, the ability to understand, conduct, and apply research finding is indispensable for any competent medical practitioner. Our aim is to cultivate a research culture that goes beyond the classroom, inspiring our students to continue pursuing scientific inquiry throughout their careers. The skills they gain through this research component, critical thinking, data analysis, and scientific communication, will not only prepare them for better doctors, but also equip them to be leaders in healthcare innovation and policy. Today, we acknowledge the tremendous effort of Department of Community Medicine, which has tirelessly coordinated this research component and guided our students throughout the process. Your dedication has been pivotal in creating a supportive environment that fosters scientific curiosity and excellence. We also extend our deepest gratitude to the academic staff who have served as supervisors, providing mentorship and expertise. Your commitment to nurturing the next generation of medical professionals is truly commendable. A special thank goes to our external evaluators, whose insight and feedback brings an invaluable external perspective to this symposium. Your contributions ensures that our research standards remain rigorous and our students receive well-rounded evaluations of their work. Our students, I say this, you have taken the first step in a lifelong journey of learning and discovery. Embrace the spirit of inquiry. Continue to ask questions and let this experience ignite a passion for research that will stay with you long after you leave these halls. Thank you.
Thank you, sir. To commence our symposium, I would like to invite Chair of the Undergraduate Research Symposium, Professor Nuwan Wickramasinghe, to address you all.
Very good morning to all of you. Very good morning to all of you. It indeed gives me great pleasure to speak a few words at the commencement of this 6th Undergraduate Research Symposium. As Janet mentioned, I would like to extend my heartfelt gratitude to all of you who have joined with us today, especially for the expert panel of evaluators who have joined with us despite your busy schedules. We know you all have exams, teaching, and other academic commitments. And despite that, thank you very much for joining with us today for this event. And this 6th Undergraduate Research Symposium of the Faculty of Medicine and Life Sciences, we are conducting it as a virtual event for the 4th consecutive year. And this year, this symposium will feature the research findings of 30 undergraduate research groups. And as we all know, how important and how demanding the ever-increasing necessity of inculcating research culture in medical undergraduate curriculum. Because of that, our faculty has introduced this Research in Medicine module early in their medical curriculum. And we are extremely happy as well as proud to witness that our junior budding researchers not only have presented in our undergraduate research symposia, but also in national as well as international conferences. And more importantly, they have won some research awards as well. And at this juncture, I would have to mention a special group of dedicated and enthusiastic professionals that is none other than our academic staff members. Because of their supervision and guidance, our junior budding researchers have been able to conduct very fruitful research. And at last but not the least, my dear students, for evaluative purposes, we will be selecting some best poster presentations. But remember, as I repeatedly say, you all are true winners for the excellent work that you have carried out so far. And we believe that this would be a stepping stone for many more fruitful research to come in years. And I hope that you all will have a very fruitful day. Thank you.
Thank you, sir. Let me introduce the expert panel who will be evaluating today's presentation. Dr. Damitha Gunwardena, Board Certified Specialist in Community Medicine, Senior Lecturer, Department of Community Medicine, Faculty of Medicine, University of Peradeniya. Dr. Ishanka Thalagala, Board Certified Specialist in Community Medicine, Head, Senior Lecturer, Department of Community Medicine and Family Medicine, Faculty of Medicine, University of Moratuwa. Dr. Manoja Pereira, Board Certified Specialist in Community Medicine, Head, Senior Lecturer, Department of Public Health, Faculty of Medicine, University of Kelaniya. Dr. Samthi Navaratna, Board Certified Specialist in Community Medicine, Head, Senior Lecturer, Department of Community Medicine, Faculty of Medicine, University of Peradeniya. Professor Champa Ranatunga, Professor in Immunology, Department of Microbiology, Faculty of Medicine, University of Peradeniya. We would like to remind a few housekeeping rules for attendees. Please keep background noises to a minimum. Make sure mute your microphones when you are not speaking. This session will be recorded and we will share the live YouTube link in the chat of the Zoom session. Expert panel will ask questions for 3 minutes from all the members of your research group. So now let's commence our first presentation. The group members are Abesekara, SDAM, Abevikrama, LCAT, Amarasinghe, AAPN, Amarasinghe, AAP, SV, Ambagahawatta, PGCN, Anupama, DMA.
Good morning to you all. Here we are presenting our research poster presentation on unveiling drug abuse dynamics, insights from close associates of active drug users, a qualitative exploration in a suburban community in Anuradhapura district, Sri Lanka. I, Abesekara SDAM, presenting on behalf of Research Group 1. Drug addiction has become a pressing public health problem, affecting in a global scale. According to global statistic data in 2023, among drug-using population, 5.8% were in the age group of 15 to 64. We thought to explore this intriguing matter. So why did we choose this topic? As you can see, there are two persons. One is person A, another one is person B. They are siblings living in the same house, living under same parents and living in the same environment. But one is a drug user and another one is not. So what could be the reason for this difference? To find answers for this, we searched many articles. While searching, we could identify numerous articles targeting person A, while there were none targeting person B. So as I mentioned, non-drug users' perspectives are oftenly overlooked in the research setting. Because of that, objective of our study is to explore the perspectives of close associates of drug users regarding avoidance factors and biopsychosocial determinants of drug abstinence. For that, we conducted a qualitative study in Anuradhapura area. Our participants were close associates of drug users who are in age between 18 to 64. We employed snowball sampling technique, and for the data collection, we conducted semi-structured in-depth interviews. Using thematic data analysis, we analyzed our data. Before all these procedures, we obtained ethical clearance as well. Within our study, we conducted 15 in-depth interviews until we reached the data saturation point. So, who were our participants? Our participants were siblings of the drug users, trusted relatives of the drug users, and close friends of the drug users. According to the findings, we could identify 4 main themes and 23 sub-themes. Our themes were nature of the relationship with the drug users, factors supporting drug use, factors supporting drug use, and consequences of drug use. When we look at the nature of the relationship with the drug user, we could identify that most of our participants' close contacts were using drugs, and they were having different level of relationship with the drug users. When we look at the factors supporting non-drug use, it was operating in personality, family, health, and religious levels. The strength of mentality of our participants were a major protective factor for them not to use drugs. And most of our participants have experienced that drug users have stopped using drugs following their children's birth. One of our participants stated that my brother is a user for 15 years. He stopped using after his daughter's birth. And most of our participants are not using drugs because they think drugs are toxic and drugs are giving bad effect for their health. And within our study, we could notice that some of our participants are not using drugs because of their religious adherence. When we look at the factors supporting drug use, we could identify social factors, family factors, personality factors, and personal factors. Peer pressure was a major notable associated factor with the drug use. And according to our participants, some of them have experienced that. Most of the employers who are drug users try to pay their workers with drugs instead of money to influence their workers to use drugs. One of our participants stated that he says that he is not being paid for his work and his employer tries to pay him with drugs instead of money. Most of the drug users have first used drugs to quench their curiosity. So the curiosity have become a major personality factor associated with the drug use. And relationship issues such as breakups also a major associated factor with the drug use according to our findings. When we look at the consequences of the drug use, we could identify consequences toward users, towards society, and towards users' families. Most of the consequences of the drug use mostly affected the drug users themselves because according to our participants, most of the drug users were having poor economical status, poor social status, and most of them are facing frequent legal issues. One of our participants stated that some of the users are working as servants in the dealers' homes for drugs, When we visited the areas for our interviews, we could notice that people in that area, as well as our participants also stated, theft in the area have been increased due to this drug use because most of the drug users try to steal anything they find to fund their addiction. And drug users have become a major economical burden for their families as well. So according to our study, you could notice that most of the drug users' families are taken care of either by their parents or their wives. So according to our findings, we could identify that most of these factors are modifiable through effective public health interventions. So we suggest to strengthen existing policies and legal frameworks and to develop interventions targeting early childhood and family stability to promote drug abstinence. With that suggestion, we conclude our research poster presentation and we thank to all of our participants for their dedicated time. And thank you so much for your attention.
Now, the presentation is open for the discussion.
First of all, to all of you. Actually, it's a nice presentation and an interesting topic is also a bit of an interesting and timely kind of thing. So, first of all, I would like to know during your literature search, did you found any quantitative kind of studies done in similar on similar topic on similar kind of population? Quantitative kind of studies.
Thank you so much for your question, sir. But during our literature search,
Sorry, I couldn't.
thank you so much for your question, sir. During our literature search, we could not identify any quantitative research targeting these topics.
So why you decided to go ahead with the qualitative approach rather than quantitative if you couldn't find any preliminary kind of quantitative study on the same?
So when we look at our topics, sir, so we first thought to do we decide what to do with this topic. So first we thought do this with quantitative or qualitative. So when we look at these topics, sir, it is mostly suitable for the qualitative research because most findings we do the interviews and we get the findings, sir. So until data saturation point, we can gather the data. So it is more suitable for the qualitative research.
Right, good. Even other members can join, right? So during your in-depth interviews and during the analysis and at the end, did you able to find out any kind of preventive measure which was suggested by the group you have studied?
Thank you for the question, sir.
Anything comes from their side?
Yes, during the interviews, we found that our participants stated that the early preventive methods, like when we address the they stated that the school is the best place to give some preventive methods like education for the children is best for the prevention for the drug addiction, sir.
Right. So, and my last question, actually, did you notice any difference based on the relationship these participants have had with the drug addict? Because they are, I mean, you are having only 15, sample. So, did you able to find any difference? And what is the breakdown of that? I mean, their relationship.
Thank you for your question, sir. Actually, we noticed that there are various type of relationships among non-drug use and drug users. Those are family members, siblings, parents, and close friends, and also the business type or their jobs, the partnerships, or those kind of relationships we identified among those.
Okay. Okay, right. Thank you.
Thank you.
Thank you, sir. Now we will move on to the second presentation. The group members are Aponso GMUS, Athauda ARUTB, Attanayaka PAMHKRB, Attanayaka AMGCB, Askia AMRF, Balangoda GBSK.
Good day, everyone. My name is Udara Thaver, and today I'll be discussing a critical issue that affects young women globally, including right here in Sri Lanka, menstrual hygiene management. Menstrual hygiene is often an overlooked yet an essential aspect of public health, and inadequate management reinforces gender equality in many parts of the world. In Sri Lanka, female undergraduates face similar challenges. Limited access to sanitary products and poor hygiene facilities have a direct impact on their daily lives and educational performance. So in our research, we are aimed to determine the level of knowledge and practices surrounding menstrual abnormalities among undergraduate females at Rajara University. Specifically, we want to explore how these issues affect their physical health, academic performance, and overall well-being. So, we conduct a descriptive cross-sectional study among the undergraduates at Rajara University. The data was collected through self-administered questionnaires based on 3 languages. These questionnaires focus on menstrual patterns, symptoms, and the overall impact on their daily activities, ranging from academic involvement to mental well-being. So, in our research, we uncovered several significant findings. Total of 387 students participated to our questionnaire. Out of them, Faculty of Applied Sciences are mostly participated, followed by Social Sciences, Technology, Management, and Agriculture. 63.8% of participants experienced menarche between the age of 11 and 13, while 31.3% reported it between 14 and 16 years. Also, most of the participants reported having a regular menstrual cycle. So, when we look at the common symptoms during menstruation, we found out that 93.5% of participants reported abdominal pain, 85% of experienced back pain, 74.4% noted an increase in pimples, while headache affected about 62.3%. Breast tenderness was also common, affecting nearly 50%. Some participants also reported abnormal menstrual symptoms, with passing clots being the most common, followed by bleeding with flooding and prolonged bleeding or spotting, about 16% of cases. A small percentage report the absence of menstrual period for 3 consecutive cycles. So, to manage these symptoms, more than 55% of participants used paracetamol. 17% relied on homemade remedies, while 8% turned to herbal medication. Oral contraceptive pills, mefenamic acids, and domperidone were also used, but by a smaller fraction. Now we are moving to the academic impact. 57.4% of participants reported that menstruation negatively affected their academic activities. 39.3% missed lectures, and 40.8% had difficulty in concentrating during this time. So this highlights the significant role that menstrual health plays in academic performance. Participants also face social issues. 51.9% report that menstruation influenced their social relationships. 43.2% experience difficulty in traveling, while others suffer from social anxiety or were unable to engage in sports. Finally, we look at menstruation-related challenges within the university environment. 25.8% of participants cited unavailability of sanitary pads. 18.1% expressed concern over inadequate and unsafe washrooms, and 13.2% had difficulty in disposing of sanitary pads. Additionally, inadequate water supply was an issue for around 13.2% of students. So in conclusion, the finding highlights the urgent need for better menstrual hygiene management systems at Rajara University and similar institutions. Addressing these issues would involve improving access to affordable sanitary products, upgrading hygiene facilities, and educating students about menstrual health. So by tackling these challenges, we can help to reduce gender disparity in education and promote a more supportive environment for female students. Thank you.
The presentation is open for the discussion.
Okay, thank you very much for your interesting study and of course your interesting presentation as well. So I have few clarifications first to make. I need, in fact, can you please tell me what was your calculated sample size and what was the sampling technique that you all used?
Actually, thank you, madam, for your question. Actually, madam, we use the whole population sample. So we have taken the sample size, the whole university students. So we have collect the whole study population sampling.
Right. So you have about 300 odd amount. I think it is 387. So that came up to what was the response rate?
387 students response, madam.
Yeah, what was the yes, that is what is the response rate compared to all the students in the university, all female students? Have you all calculated the response rate?
Yes, madam. Actually, we have found out that in that period of time, the available students we have taken for the research, madam, because some students may have the academic problems and that. So we have collected that 387 students, all students have responses.
Right, okay. So having this study findings, what are your recommendations? Let's say, what are your recommendations to the VC of your university, having these findings of your study?
Yes, madam. Actually, we have found out that we have to develop our infrastructure in our university.
If you don't mind, can you allow someone else to speak as well? Sorry.
Yes, madam. As a conclusion, we finally come to a conclusion and we decided to develop the infrastructures of each faculty to export the sanitary products and other stuff. So, we decided to improve the awareness regarding the menstrual issues among the faculty students as well.
Right. Okay. So now you have found out that about 4% students were bullied, and there was social anxiety about 21% of the students. So what are your plans to improve this situation among the students related to menstrual health issues?
Actually, madam, we are hoping to educate more about these aspects throughout university students. So these matters are important for their own personal interest, as well as their own academic as well as the social issues. They have to know aware about these issues. So we have to give more sessions around students to know about these facts, that these are important for their life as well as for others.
Okay. Okay. Right. Okay. Thank you so much. Congratulations again.
Thank you.
Thank you, madam. Now we will move into third group. Group members are Babarendra BKO, Bandara AHMDM, Bandara BMGKM, Bandara RMCN, Bandara RMTN, Bandara WMKR.
Hello, I'm Nedu Bandara, a fourth-year medical undergraduate from Group 3 of Rajarata University of Sri Lanka. So today I would like to talk about the topic on knowledge, attitudes, concerns on childhood immunization in post-COVID era among Sinhala-speaking mothers in Anuradhapura, Sri Lanka, a qualitative study. So, childhood immunization through vaccination is one of the most successful public health intervention in the preventive healthcare sector. So it is considered one of the main public health achievement in the 20th century. Globally, childhood vaccination has contributed to significant reduction in morbidity and mortality related to vaccine preventable diseases. And there's a global goal to achieve 90% coverage for essential vaccines given in adolescence and childhood and achieve 50% reduction in the number of children missing out in vaccinations by 2030. And according to WHO, vaccine hesitancy was also listed as one of the most important global health threats in 2019. In Sri Lanka, the expanded program of immunization or the EPI schedule include vaccines against many preventable diseases and has achieved significant progress in preventing diseases such as diphtheria, pertussis, neonatal tetanus, and poliomyelitis. And they have eliminated some diseases like poliomyelitis. And the knowledge and attitudes of parents towards vaccination and the EPI schedule are crucial to increase the participation in immunization program because the vaccine acceptance by children and young adolescents is dependent on the parental consent. So with the COVID-19 pandemic, a hesitancy on vaccine among those who are young, poorly educated, and in rural communities, and those with poor socio-economic background has been observed worldwide. In Sri Lanka, concerns about the shortage of medicines during the economic crisis and also the unnecessarily sensational reports of vaccine adverse effects have been observed. The influence of the above factors on vaccine acceptance related to childhood immunization has not been studied in rural Sri Lanka. So therefore, we wanted to find answers for the following questions. Are there any disparities in age-appropriate vaccination in rural Sri Lanka? Are caregivers concerned about the childhood immunization after the COVID-19 pandemic? And what are the driving factors of negative attitudes on childhood vaccination in rural Sri Lanka? And what are the strengths for the childhood vaccine acceptance in rural Sri Lanka? And there are a large number of quantitative studies conducted globally to assess the attitudes of parents about the routine childhood immunization. Although in the Sri Lankan context, the number of qualitative and quantitative studies conducted still remain very minimal in number. So to find answers to our questions mentioned above, we thought of doing this qualitative study. So our main objective was to explore the knowledge, attitudes, and concerns and positive and negative influencing factors on childhood immunization among Sinhala-speaking mothers of under 14 years of age in Anuradhapura. So for our study, we selected mothers of children under 14 years of age who are in pediatric wards of Teaching Hospital Anuradhapura, and we selected participants using a consecutive sampling method. And in-depth interviews were conducted using a semi-structured interviewer guide which was prepared focusing on areas like knowledge, concerns, and attitudes of childhood vaccination and their related factors relating to vaccine hesitancy. And these interviews are conducted until the data saturation point is reached, right? And these interviews are audio recorded. So in our study, we interviewed 20 mothers, age ranging from 21 to 50 years, and parity ranging from 1 to 3. And also they had a variable educational status, various religions and occupations. And after the interviews, we transcribed each interview and then we code and then thematically analyzed in Sinhala manually, and results were interpreted in English. So through thorough analysis of our gathered information, we were able to arrive at several important remarks. All the participants knew the sources of accurate information, and they had a basic idea about what is a vaccine and what are the vaccine-related complications and their management at home level. Although they had deficits in their knowledge regarding the specific coverage of each vaccine, they knew where to seek the correct information from, like public health midwife and child health development record. And almost all had a negative attitude and concern about the COVID-19 vaccine, but that has not affected their trust in the childhood immunization program. And also the television news reporting has triggered concern about the childhood vaccination system, but these have not led them to miss any vaccine. This is very important. So the trust based on a good relationship with the midwife is the key factor for the mother's trust on childhood immunization. So these participants mentioned that they had a very good relationship with the public health midwife in their, as they know public health midwife as a person to seek information about their child. So this bond between the public health midwife and the mother has been a key factor for the participants' trust regarding the child immunization program. So thereby we arrived at our final conclusion. Despite concerns, mothers considered childhood immunization as a must, and public health midwife had a significant role on gaining and maintaining the strong trust on the childhood vaccination system. So this brings to our end of our presentation. Thank you very much.
Now, the presentation is open for discussion.
Thank you for that interesting presentation, and it was a very professional style of delivering. So congratulations, specifically for the presenter. I am interested in your sampling method. So you are talking about consecutive sampling. What did you exactly mean by that? Consecutive sampling. That's what you said, right?
We force participants putting out heavy ID. Randomly select consecutively the participants in the period for it to make our criteria.
Okay, because you have conducted the qualitative research, what are the qualitative research sampling methods you know? Consecutive is a qualitative research sampling method. Do you know any other, maybe more suitable sampling methods that you can use in qualitative research? Where you can select the participants based on their either, socio-demographic characteristics, their education level. No. No. Have you ever heard the thing called purposive sampling, judgmental sampling? Yeah. Okay. I think the time is up. Is it because? No.
No, ma'am.
Okay. Okay. So, how can someone else answer, please? So, how transferable do you think the findings of your study are to the rest of the country?
The sample we selected is in the rural Sri Lanka. We have no thoughts of, we didn't thought of generalizing our findings. So I think that findings of our research is suitable for our population, the population in the rural areas only. So if we have thought of transferring the findings to the general population, we thought of expanding our population with more different.
What do you mean by expanding to include whom, how can you improve the transferability of your findings?
We have identified several limitations in our research, madam. They are we have chosen a population who are having health-seeking behaviors and also comparatively low socioeconomic status and educational status. So we are thought of expanding our research to a more urbanized community who have more education status and more socioeconomic status. So that's what I mean by.
Ethnicity and religious backgrounds don't matter?
Yes, it matters, madam. We have to protect the smaller community, but we are hoping to include family population as well, madam. And also we have included single-speaking Muslim and both Buddhist in our population.
Okay, right. Thank you. Okay.
Thank you very much, madam. Now we will move into fourth presentation. Group members are Basnayaka BMMPK, Basnayaka BMVD, Boteju WHY, Buddhika PGS, Chamatka DCM, Chandipani LBS.
Hello everyone, I am Hashini Muteju from Group 4 of the 2018-19 batch Faculty of Medicine and Allied Sciences, Vajradhara University of Sri Lanka. For the research in medicine in community medicine, we have done a research on the impact of acute stress on attention among older level school students. To understand why we did this research, let's have some background on our research. The main focus of our study was the human brain. The human brain has many unresolved mysteries. Therefore, we were very keen to study about it. Out of many functions of the brain, we have selected the cognitive component. In the cognitive component, we were interested in the behavior called attention and the factors associated with it. One of the most commonly associated factor with attention is stress. People generally consider stress having a negative effect on attention, and that inspired us to explore more on their relationship. It made our research involve three components: attention, stress, and the correlation between them. Attention is a cognitive brain mechanism that allows individuals to focus on sensory inputs and thereby process them in an order. Three attentional networks have been defined based on the anatomical and functional effects of attention. They are alerting, orienting, and executive control. Stress is a state of worry or mental tension caused by a difficult situation. Out of many variants of stress, we focused on the effect of acute stress on the attention of convenience of measuring the stress. And that has set our objective to assess the impact of the acute stress on attentional networks. In order to cover our objective, we conduct a cross-sectional study among the older level school students in a randomly selected mixed school in Anuradhapura district. The randomly chosen school was Niwattaka Chaitya College. We selected the older level students as they were near their exam, and therefore we could expect a good variation of stress levels among them. And also, we considered the importance of the older level exam in our education system, as well as the higher level of understanding among them than the lower grade students when selecting the sample. We calculated minimal sample size was 67, but we included 75 for the convenience of dividing them into groups of 50. To measure the attention, a computer-based study called the Attentional Networks Test was used. It was implemented using a software called the Infisit V6.0 on the computers of School IT Lab under the permission of school authorities. Students were asked to perform a task displayed on the computer using the keyboard, and reaction times were measured. Acute stress was measured using a scale called Perceived Stress Scale, which was a paper-based test where the students were asked to answer the set of questions by themselves. This scale measured the stress of a participant within the past 3 months. Scoring was done according to a scale. Above collected data was analyzed using the SPSS software, and the Pearson correlation value was calculated. A total of 75 students of grade 11 grade 11 of the particular school participated in the study who were around the age of 15 years. As the results show, we observed that stress levels of the students range from 1 to 33 in the perceived stress scale, which indicates an adequate range of variation. The levels of attention as shown in the graphs according to each component of the attention. Please note, these values are not pure reaction times, but another set of values calculated after measuring the reaction times, so the unit of these values are not indicated. When considering how acute stress has affected On the components of attention, no statistically significant association could be found between them. The p-values were significantly higher as denoted here. When calculated the Pearson correlation for the components of attention, after plotting them as shown in the graphs, we found that alerting component has a positive correlation, while both orienting and executive control attention components had a negative correlation with acute stress. But the correlation value we obtained were very small, so that they could not make any statistical significance. The respective values are denoted here. As a conclusion, no significant association was found between any of the attention components against the acute stress, but directions of the correlations suggest an association where the alerting is improved while acute stress, while orientation and executive control is hindered. We suggest that this topic should be explored more and the findings should be to need to improve the efficiency of teaching and learning practices at school level. As a final note, we would like to mention that the attentional network test may need to be reconsidered when applied to a teenage population under practical circumstances. Thank you.
Now, the presentation is open for the discussion.
Right. Thank you very much. Can you hear me? Yeah. Okay. Thank you very much, and congratulations for a job done well, and to the presenter also for presenting it very clearly. I have a little question on actually any limitation. If you all have any limitations of this study, can you state before I come out with any of them? I would like to see whether you all recognized your own mistakes or room for any improvements.
Selecting a school. Thank you, Madam, for the correction. We have limitation in selecting a school, as there are limited lab facilities in schools that we have assessed attention using a computer-based method. So we have to randomly select which school for this study. So we had the limitation when selecting a school, and when we communicate with students in school, as they are 15 years of age, we had limitations as they didn't understood the method very well. Those are limitations.
Yes, carry on. Do you have anything to add? Any others who want to contribute to the same question?
In this case, madam, we have assessed acute stress, but the scale we used was a scale which measured acute stress within 3 months. Actually, we wanted...
Yeah, good. I wanted that. Yeah. So one thing I wanted to point out is, how did you actually define acute stress for your study? Did you define it in any way? I mean, it's immediate stress, or, or within 1 hour. How did you do a literature review and find out how to define acute stress?
We couldn't find any exact time period to define acute stress, madam. But by definition, it was given that the stress developed due to recent conditions, and the recent condition we generally found was within 3 to 4 months, madam.
Okay. Right. So why did you choose this O-level students? Was there any particular reason?
There are studies that have done in undergraduate level regarding stress and attention, but there are no evidences that researchers have done in O-level students level or student level. So we have selected this research for that purpose.
How long before the O-level exam did you actually have this test on them?
1 month.
1 month before. So you were able to get the ethics approval and the administrative clearance for that, I hope. Did you? Right. Okay. So then you have just chosen one school, right? Out of all the schools. How many schools are there in Anuradhapura, whatever this education zone or whatever the zone you all have chosen?
In Peach, madam, there were 5 schools, madam.
5 schools with computer.
Next schools, there were 5 schools. And when we considered the available laboratory facilities and when we discussed with the principals for the academic schedules, we could only gain access to the particular school we selected, madam.
So you took all the students in that school, or how did you do the sampling? Not clear as to how did you did the sampling.
Madam, the students were selected randomly. We didn't contact the students directly. We first coordinated with the principals, and then the class teachers were come in contact with us, and we have given the instructions for the class teachers to contact the students, and actually they have given the consent forms for the students, and out of the students who have given the consent, we have selected 75 students, madam. There was no specific method of selection.
Did you calculate the sample size, the minimum sample size required? So what was that?
It was 67, madam. It was according to a software calculation.
How did you calculate 67? How did you come up with that number?
In the literature review, madam, we have found that there was a previous study which was not using the perceived stress scale, but the cortical levels were measured for stress. And in that one, around 35 participants were used. And
so you think it's correct to use that for your purposes?
That was the most close study that we could find for our topic, madam. There were no direct related studies that we could use.
When you cannot find studies like that, what should be your option, the correct method? Okay, I'll pass on that. So these tools, are they validated for the Sri Lankans? I assume you all looked at them, read about them. Were they validated in any way?
Yes, madam. They have been not particularly for Sri Lankans, but they have been validated to use under the age ranges that we have conducted our study.
Right. Okay, thank you. Over to the next exam.
Thank you very much, madam. Now we will move on to 5th presentation. The group members are Darshika GL, Chandaseri GVP, Chaturangi BAM, Dasanayaka IDSM, Dayakanta JBH, Dayaratna PWJC.
Good morning to you all. I am PWJC Dayaratna, the group number 5. Our research title is Antioxidant Capacity and Total Phenolic Content of Selected Beverages and Their Acute Effect on Serum. Non-communicable diseases account for nearly 90% of the disease burden in Sri Lanka, and oxidative stress is a major determinant of non-communicable diseases. The inherent antioxidant defense system in the human body is markedly adapted at counteracting toxic free radicals produced in the human body. Furthermore, certain phytonutrients found in plants, including polyphenols, flavonoids, tannins, alkaloids, and terpenoids, also function as antioxidants. Therefore, herbal tea consumption is becoming very popular mainly because of their antioxidant properties associated with health promoting effects for humans. Although many studies have elucidated the presence of antioxidant in herbal beverages, data are lacking on traditional underutilized herbal beverages in Sri Lanka, and the changes in antioxidant levels in the human body with the consumption of these herbal beverages. Therefore, we decided to conduct our research as continuation of a recently conducted research study on effect of herbal beverages on postprandial blood sugar. The research elucidated that the homemade herbal teas Coccinia grandis or Kovacca and Scoporia dulcis or Valkottamalli control postprandial blood glucose level, and these effects were which is comparable to the effect exerted by the reputed beverage green tea. However, no data were available on the effect of these tea varieties on the antioxidant capacity of the human body. Our research objectives were to determine the antioxidant capacity and total phenolic content of selected beverages and their acute effect on serum antioxidant capacity after consumption. Kovacca or Coccinia grandis and Valkottamalli or Scoporia dulcis were the test tea beverages. These leaves were washed and oven dried and then pulverized to a fine powder. The powdered leaves were packed in tea bags, including 2 grams in each tea bag. During the preparation of beverages, the tea bags were steeped in 125 milliliter of hot water at 70 Celsius and brewed for 3 minutes to make the tea infusion. Green tea was used as the standard beverage. The in vitro total phenolic content of the beverages was assessed by Folin sear culture method and expressed as gallic acid equivalent total phenolic content per 1 gram sample. In vitro antioxidant capacity in tea beverages were assessed by ABTS free scavenging assay against Trolox. We conducted our research as a cross-sectional experimental study and recruited 13 healthy individuals with normal BMI. Sample size was selected based on previously published similar studies. The volunteers were informed to have their usual meal for breakfast 1 hour prior to participation in the study and were asked not to take any other drink or food afterwards. Venous blood samples were obtained before consumption of the beverage and 1 hour after the consumption of the beverage. The ABTS free radical scavenging assay was used to analyze the antioxidant capacity of each serum sample as in triplicates. According to the obtained result, the total phenolic content and in vitro antioxidant capacity were highest in green tea, followed by Valkottamalli. Total phenolic content had a strong positive correlation with antioxidant capacity. None of the beverages showed considerable increase in antioxidant capacity in serum 1 hour after from the consumption of the beverages. However, further in vivo studies can be conducted measuring the antioxidant capacity at 30 minutes or before 30 minutes as the antioxidant effect would be observed before 1 hour. It can be concluded that Valkottamalli tea has a significant high total phenolic content compared to the Kovacca tea. Although not significant, Valkottamalli had higher antioxidant capacity than Kovacca tea. However, green tea had a significantly higher total phenolic content and in vitro antioxidant capacity compared to the Valkottamalli tea and Kovacca tea. A considerable level of in vivo antioxidant capacity was not shown by all the 3 beverages after 1 hour from the consumption. Thank you for listening.
Now the presentation is open for the discussion.
Can you hear me? Yes, right. Okay. Congratulations. It's a very interesting study that you all have done. So I'd like to ask, in your assay, on the following assay for total phenolic content that you did, is there other, other than phenols, are there any other substances that can give you positives, sir? Or are you sure that it will measure only phenols?
Thank you for your question, Magda. There are so many antioxidant contents can give antioxidants, but phenol are the only one we can measure in our setup. That's why we use it.
Right. I mean, in the assay that you use the Folin Siocolto assay, right? Yes? Yeah. Are there any other substances that could be in the tea that could give you positives for that assay?
Yes, madam, but their amount is very low, madam.
Amount is very low. Yeah.
The major compound in the urine.
Yeah. Okay, good. So, now you found a very high correlation between the antioxidant capacity and the phenolic capacity and the total phenol content. Yeah. Did you expect that correlation, or is it something unusual? Or do you think it's normal? Is that something you expected? And why is that? Anyone can answer. Yeah. Sorry, a little louder.
Total phenolic content gives, when there is high total phenolic content, then there is normally high antioxidant capacity. But in our in vivo study, there was no significant increase in all three beverages after consumption from 1 hour. But in vitro studies, there was high antioxidant capacity, also high total phenolic content. But,
Why do you think why do you think your in vitro isn't showing it? What are your possibilities?
In vivo study,
Yeah, sorry, your in vivo. Yeah.
We measured after 1 hour the antioxidant capacity, but we think if we have measured after 30 minutes of the after giving beverage, sometimes it may be give high antioxidant capacity than after 1 hour from the consumption of tea.
Right. Okay, good. And who prepared the Valkotamali and the coac?
We have leaves collected from this region and we have made them.
Right. And so for all your experiments, you use the same preparation that you had used?
Yes, madam. Green
Yeah.
fibers were taken from the shop and other two leaves are prepared by us.
Right. If someone else can answer. So, do you think that, say that preparation, your results are valid for all Valkotamali and all Goa Cup? Do you think that preparation alone can tell you what the results for antioxidant capacity is going to be? Can anyone answer? Yeah.
Actually, madam, we use the that plant which is authenticated by Peradeniya Botanical Garden. But we know that antioxidant capacity and phenolic content inside the plant is varied with soil conditions and water and those things. So it can be various according to that geographical things and that kind of things, madam.
All right. Okay, good. Congratulations. Well done.
Thank you.
Thank you very much, madam. Now we will move into sixth group. Group members are Dharmaratna WDSD, The Gunawardhana HDA, the Soisa ALS, Devendra CUD, Devmini WKD, Dharmasena END.
Hello everyone. I welcome you all to the 6th Undergraduate Research Symposium of Faculty of Medicine and Allied Sciences, Rajaratnam University of Sri Lanka. Today, I'm going to conduct our research poster presentation on incidence of transfusion-transmitted hepatitis C infection among beta thalassemia patients registered in Anuradhapura Thalassemia Center. My name is WKD Devmini, and here are our group members. As you all know, hepatitis beta thalassemia is a condition which has a significant prevalence in the world. When we consider about the state of thalassemia in Sri Lanka, Anuradhapura district has the largest cohort of patients. Patients with this hereditary blood disorder are encountered with hemolytic anemia and often require regular blood transfusions that could result in iron overload causing hepatocellular damage. These blood transfusions would in turn lead to bloodborne infections such as hepatitis C. Hepatitis C is a viral infection that could result in the chronic infection and liver cell damage. It would worsen the already existing liver damage in these beta thalassemia patients. Determining the incidence and prevalence of transfusion-transmitted hepatitis C in beta thalassemia patients registered in Anuradhapura Thalassemia Center was our objective in conducting this research. We wanted to better understand the burden of hepatitis C viral infection among these patients and assess the effectiveness of current screening protocols. We conducted our research as a retrospective cohort study, taking 293 thalassemia patients who are on regular blood transfusions from 2021 to 2023 in Anuradhapura Thalassemia Center. We obtained the secondary data of 293 patients registered at regional center, and their hepatitis C viral infectious status was confirmed with the virology laboratory at Anuradhapura Teaching Hospital. In the virology laboratory, the hepatitis C viral infection screening was done by antigen-antibody combined ELISA testing. Those who tested reactive for the screening test were confirmed by RT-PCR testing, which was more sensitive in detecting active infection. For the data analysis, we used SPSS software and we obtained the ethical clearance from Ethics Review Committee of Faculty of Medicine and Allied Sciences, Rajaratnam University of Sri Lanka. Now, let's move on to the results that were obtained from this research. Among the 293 patients whom we obtained the data, 64% were beta thalassemia diagnosed patients, with a majority of males accounting for 53%. In the year 2021, a total of 175 were screened for the hepatitis C viral infection, and among them, 29% were tested reactive. In the year 2022, a total of 193 were screened and 39% were tested reactive. In the year 2023, a total of 214 were screened, and out of them, 29% were tested reactive. In the year 2021, a total number of 49 patients underwent diagnostic RT-PCR testing, and among them, 33% were tested positive for the hepatitis C viral infection. In the year 2022, a total number of 39 patients underwent the diagnostic testing, and among them, 31% was tested positive. And the year 2023, 68 patients underwent the RT-PCR as the confirmatory test, and 21% were tested positive. the prevalence of hepatitis C viral infections in beta thalassemia patients for the years 2021, 2022, and 2023 was 9.14%, 6.21%, and 6.54% respectively. From 1st of March 2022 to 1st of March 2023, the period prevalence of the hepatitis C viral infection among the beta thalassemia patients was 4.78% and the incidence was 2.14%. So, despite the efforts in screening blood products, incidence and prevalence of hepatitis C viral infection among beta thalassemia patients remains at a significant number. The reasons for this significant prevalence could be due to deficiency in performing PCR tests to detect the hepatitis C RNA in blood in the early stages of infection, false negative test result due to technical errors, blood donation by asymptomatic carriers who test non-reactive for the screening test because they are still in the window period, or a low viral load in the early stages. Screening the blood products with only antigen-antibody combined ELISA testing might miss the active infection during the window period. So, here we suggest the necessity of incorporating PCR testing alongside serology to ensure precise detection of blood products infected with hepatitis C. With this, we conclude our research poster presentation. Thank you and have a nice day.
Now, the presentation is open for the discussion.
Congratulations, and it's a nice presentation, and bit of a system gap actually we are trying to highlight. So to your knowledge, while you are doing your literature search, did you find any bit of a large kind of a secondary data set published with regard to Sri Lankan country? Because you are also dealing with a part of secondary data, so I'm asking, is that data has been already published as a not only one center from the several centers available in Sri Lanka?
Thank you for question, sir. Yes, they have we found a recent research conducted in 2014 and 15 here, which has been the four thalassemia centers, main four thalassemia centers, including Chilo, Badulla, Anuradhapura, and Ragam, has been conducted in those four thalassemia centers. We took those research findings to our research.
Yes, my question. The next question is that problem has been already highlighted with a huge kind of a secondary data set. So why you think that it is a important question to answer just using that Anuradhapura center? Any reasons why you have done this time?
Thank you for the question, sir. Actually, during our one of our clinical session, we found a beta thalassemia diagnosed patient who is showing signs and symptoms of hepatitis viral infection. Actually, signs and symptoms of chronic liver cell damage, and we were suspicious of hepatitis infection. So his blood was sent for the virology studies, and he was diagnosed with hepatitis C viral infection. So we were bit curious about this research with this team, and then we found the previous research which was conducted by the Ragama faculty on this topic. So in order to fulfill the knowledge gap between that research and the recent current status, we thought of conducting this research.
So what is the current screening mechanism used by the transfusion, the blood banks now currently?
Thank you, sir. Actually, the current screening protocol is combined antigen antibody ELISA testing.
So now they are doing PCR and ELISA both? No.
No, actually the PCR testing is very high cost. It takes a lot of cost to do the PCR testing. So only the antigen antibody combined ELISA testing is used for the screening protocols.
Yes. So so in that case, even though you found that it is important to do a PCR test, do you think it is a feasible option for the health system in Sri Lanka at the moment?
Thank you for the question, sir. PCR needs a lot of cost. Then, as Sri Lanka, we are unable to spend a lot of money for PCR, and the reagents are out of stock. Then they do ELISA only. But we suggest PCR for the PCR test for the all blood products to prevent the transmission of hepatitis C to healthy patients.
Okay, thank you.
Thank you.
Thank you very much, sir. Now we will move on to 7th presentation. The group members are Dinushan PDA, Dharmathiraka KAPM, Dias JDP, Dilshan TKD BC, Dilshara GAT, Disanayaka DMAN.
Hello everyone. I'm DMAN Disanayaka representing Research Group 7, and today I'm going to present the findings from our study on the prevalence of depression, anxiety and psychological stress among nursing officers in Teaching Hospital Anuradhapura, Sri Lanka amidst the economic crisis of 2023. Nurses are often at the front line of healthcare, facing high workloads and stress, and their mental well-being directly affects the quality of care patients receive. With the added strain of the economic crisis, their situation becomes even more challenging. This study is important because addressing mental health in healthcare workers can improve both patient outcomes and staff well-being. Sri Lanka's economic crisis of 2023 severely impacted many sectors, including healthcare. This led to shortages in medical supplies, salary cuts, and increased workloads for healthcare workers, all of which can elevate stress and anxiety. Nurses are particularly vulnerable due to their critical role in patient care, often working long hours under pressure. Studies show that chronic workplace stress can lead to anxiety, depression, and burnout, affecting performance and job satisfaction. Our study focused on nursing officers in THA because it is one of the largest hospitals in the region and serves a large population, making it an ideal location to assess the crisis impact. The objective of our research was straightforward: to assess the prevalence of depression, anxiety, and psychological stress among nurses in the Teaching Hospital Anuradhapura during the 2023 economic crisis. We also aimed to identify which factors contributed to these mental health conditions, such as work environment, marital status, and night shift duties. To gather data, we conducted a descriptive cross-sectional study. The data collection tool was a self-administered questionnaire based on the well-validated DAS-21 scale, which measures depression, anxiety, and stress. The questionnaire was distributed via Google Forms, and we achieved a response rate of 71% with 214 participants from various wards such as surgical, medical, pediatric, and psychiatric wards. Most of our participants came from surgical wards, while medical wards accounted for 21% and gynecology and obstetric wards for 12.1%. After data collection, we analyzed the responses using descriptive statistics and inferential tests to explore any association between the participants' mental health and various demographic and workplace factors. Our findings revealed that a substantial portion of the nurses were suffering from mental health issues. Specifically, 38% of the participants experienced depression, 64% experienced anxiety, and 17% experienced stress. Let's break down the results. Anxiety was the most prevalent, affecting nearly 2/3 of the participants. This is concerning because anxiety can lead to poor decision making and increased absenteeism, which directly affects patient care. Depression was present in over 1/3 of nurses. Depression can lead to a lack of motivation and lower job satisfaction, which may also increase turnover in the healthcare sector. Stress was reported by 17%, but it was notably higher among certain subgroups, like those working in surgical wards. Now, looking at the associations, nurses working in surgical wards showed higher levels of both anxiety and stress, likely due to the intense and fast-paced nature of surgical care. Ward sisters, who often have more experience and authority, reported lower levels of anxiety compared to regular nursing officers. This may suggest that experience or a higher degree of control over one's work environment can be protective. Marital status played a role. Married nurses were significantly more stressed than their unmarried counterparts. This may be due to additional family responsibilities during an economic crisis. Night duties had a clear link to both depression and anxiety. Night shifts disrupt normal sleep patterns and social life, leading to cumulative stress and exhaustion, which could explain this association. To address our study, conclude that uncertainty exists regarding whether the economic crisis has exacerbated mental health issues due to a lack of data on pre-existing conditions before the crisis. Despite this, an observed rise in depression, anxiety, and stress suggests a potential worsening effect, but further research is needed to confirm a direct link. To address this, we recommend implementing specific mental health programs for nurses, especially those in high-stress wards. Also, hospitals should consider revising shift schedules to minimize the mental health toll of night duties, and mental health screenings could be integrated into routine occupational health assessments. Further research is also necessary to explore the long-term effects of the crisis on healthcare workers' mental health. Thank you for your attention. We hope our findings contribute to improved mental health policies and support systems for healthcare workers. And we are happy to take any questions, and have a nice day. Thank you.
Now, the presentation is open for the discussion.
Okay, thank you very much, and congratulations for a timely and a very interesting presentation and a study. Well, can I please know what was the calculated sample size and the sampling technique that was used, because it was not mentioned in the presentation or in abstract.
Thank you for your question, madam. Our sampling method was simple randomized sampling, and our study design was a descriptive cross-sectional study. For the study, when we applied the sample collection calculation, we need to use prevalence of a similar study, a prevalence of depression, anxiety, and psychological stress. The prevalence, we had to use it from a similar study, and when we applied that value, the sample size that we got was higher than the total nursing officers in the country. So because of that, we could not, it was not feasible to use that sample size. And because of that, we had to collect the data over a period of 3 months. And we included all the nursing officers of the teaching hospital of Anuradhapura. However, we only received 300 response, and only 214 responses were eligible for the data analysis.
Okay, well, I don't know. I mean, I'm not quite sure whether your calculation was correct, because even if you take 50%, it will take only 384 as the number of sample that you require. So maybe cross-check again your sampling correct, sample size calculation. But okay, so in that case, could you please tell me, were there any eligibility criteria? Were there any exclusion criteria for the sample or for the nurses to be recruited into your study?
Yes, madam. We consider about exclusion criteria. We exclude nurses who are pregnant when collecting our data, and the nurses who are on leave, and the nurses already diagnosed with psychiatric illness before the our study.
Okay, so did you inquire whether they had experienced any acute trauma or anything and then excluded them as well? No. Did you hear what I said? No. Okay, fine, right. That's okay. Just one more question. Now, of course, you said certain recommendations that you would give to the director. Apart from, adding into this, could you please tell me the challenges that you faced in collecting this data from a Google form? My final question.
I'm sorry, can you repeat the question again?
Yeah, can you explain to me whether you have faced any challenges in collecting data through a Google form, because you collected data through a Google form, right? Yeah, were there any challenges? How did you reach these randomly selected nurses? How did you get the sample frame? How did you get the, emails and all that? What were the challenges that you faced? Quickly answer.
Yes, we faced a few challenges because of their already hectic schedules and heavy duties. The nursing officers were a bit reluctant to fill the Google forms. That was one of the main problems that we faced. We contacted the chief nursing officer, and he helped us. He helped us in reaching them via WhatsApp. They had WhatsApp groups in different wards, so we reached them through their WhatsApp groups, and then we physically went to those wards and reminded them of, and we asked them to fill the Google forms. However, it was a bit difficult to get all the responses because they were not, sometimes they were not available to fill the forms.
Okay, thank you. Thank you so much. Congratulations again.
Thank you, madam. Now we will move into a presentation. The group members are Disanayaka DMSM, Edirisinghe EATAK, Fahima MPP, Pasmina MJF, Fernando ITH, Fernando KHR.
Hello, everyone. I welcome you all to the 6th Undergraduate Research Symposium of Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. Today, I'm going to conduct our research poster presentation on evaluation of the factors affecting asthma control among patients from farming families, Anuradhapura. My name is DM.SM Disanayaka, and here are our group members. Asthma is a chronic condition that affects millions of people globally, including here in Sri Lanka. Specifically, in farming communities like those in Anuradhapura, asthma control can be particularly challenging due to occupational exposures. Anuradhapura is an agricultural hub where paddy farming is the main livelihood. However, frequent exposure to paddy dust during cultivation, harvesting, and storage could be linked to poor asthma control, leading to frequent exacerbations. In many of these households, paddy is stored inside the home, and while this practice is common for convenience, it can increase exposure to allergens, including paddy dust. So, we wanted to investigate how this affects asthma control. Our study aimed to address two main objectives. First one, evaluate the factors that affects asthma control among diagnosed asthma patients who are at risk of exposure to paddy dust, those who are from farming families. Second, assess the inhaler technique of these patients, as improper use of inhalers can further complicate asthma management. So, we conducted a cross-sectional study among 179 patients aged between 12 to 65, all who were diagnosed with bronchial asthma and belong to farming families. These participants were randomly selected from the respiratory clinic at Teaching Hospital, Anuradhapura. Each participant was provided with an interviewer-administered questionnaire. The questionnaire was designed to gather information on asthma control, exposure to paddy dust, and inhaler technique. For that, we used standard tools like asthma control test. Also, we assessed various stages of paddy cultivation and storage, such as sun-drying, harvesting, and in-house paddy storage. Also, we observed their usage of inhalers to determine whether they were using their inhalers correctly. We also collected data on other factors such as passive smoking and use of vaporizers, which could contribute to asthma exacerbations. For data analysis, we used SPSS software and we obtained the ethical clearance from Ethics Review Committee of Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. Now, let's move to the results. A significant 76.5% of participants stored paddy inside their home, and of these, 53.1% did so for more than 6 months each year. We found that those practicing in-house paddy storage had significantly poor asthma control compared to those who stored paddy outside their homes. Here we can see stages of paddy cultivation and asthma exacerbations during various stages of the farming process. We observed a high rate of asthma exacerbations, 64.2% during sun-drying, 62.6% during cultivation, 63.1% during harvesting, and notably 86.6% during storage period. When considering asthma control, 60.3% of participants had poor asthma control, while 39.7% had good asthma control. So, we have observed statistically significant correlations between in-house paddy storage and asthma control, between paddy storage duration and asthma control, exposure to passive smoking and asthma control, vaporizers usage with asthma control. These correlations highlight that factors such as where and how long paddy is stored, exposure to secondhand smoke, and use of vaporizers can directly impact asthma control. So, our study found that exposure to paddy dust, especially due to in-house paddy storage, significantly worsen asthma control among patients in farming families. Other factors such as passive smoking and vaporizer usage also negatively influence asthma outcomes. We recommend implementing educational programs aimed at improving asthma management techniques, inhaler techniques, and promoting the use of protective equipment during paddy handling. Addressing these factors would lead to better asthma control and improved quality of life of these patients. With this, we conclude our research presentation. Thank you. Have a nice day.
Now, the presentation is open for the discussion.
Okay, again, a good study, an interesting one. I have two questions. One is, how did you identify? Maybe you have presented it, but I haven't understood. How did you identify from the clinic list whether the participants are from farming families or not? You said you selected them randomly from the clinic list to recruit to your study.
We first went to the respiratory clinic and discussed with the doctors in the respiratory clinic, and we asked about the asthma patients and the background of them. They told that most of them are from farming families. Then we go to the patients, and we got details about the farming activities. Then we selected the patient. Randomly selected the patient, physician diagnosed asthma patient. Then after selecting the patient, we according to our inclusion and exclusion criteria, we include patients who are from farming families and who are physician diagnosed asthma patients.
Okay, so you selected them before you talking to them or after? It was a bit confusing how you described it. When did you talk to the participants? Before you use a simple random method and select them, or after you select them?
Initially, we selected asthma physician diagnosed asthma patient. Then, according to our inclusion criteria, the patient should from the farming family. So then we include them in our research.
Okay, right, okay. What did you mean by vaporizers in your research? Vaporizers?
Vaporizers we use for the mosquito.
So then you have to be specific. Have you heard any other vaporizers? No? So you have to be specific when you refer to, specifically risk factors, correlates related to anything. Yeah, okay. So so when you define farming practices, or whether they belong to a farming family, what were your specific inclusion criteria? Someone else may answer, please.
The main income source should be farming, and they should engage in that, and they should engage in the farming, and they should have physician diagnosed asthma patients. Those people are.
So any farming, and is it any farming or paddy farming?
Paddy farming.
Okay, thank you. Okay, that's all.
Now we will have 10 minutes break before moving into next half of the presentation. Please remain signed in. You can enjoy some interesting captures from previous undergraduate research symposia. Thank you. Welcome back. Let's move on to ninth presentation of the session. The group members are Fernando MIHK, Galadarachi KD, Gamagedara KGDN, Gedara KGLVK, Gunatilika WMCD, Gunavarthan GS.
It's my pleasure to take part in a post-presentation at Research Symposium, Faculty of Medicine and Allied Sciences of Rajarati University of Sri Lanka in 2024. Our research topic is the impact and extent of harassment on medical undergraduates, a qualitative study from Sri Lanka. Let's look at what is harassment. A harassment is any improper and unwelcome conduct that might reasonably be expected or be perceived to cause offense or humiliation to another person. As the definition per se, it's sure that we all have experienced some sort of harassment during our day-to-day living. Being a medical student is not an excuse to refrain from them. Medical undergraduates also undergo different types of harassment. Though these have an adverse impact on undergraduates, research in this area remains relatively limited around the world. So, we put some effort to explore this area. Let's start the floor in this way. The main objective of our research is to describe the impact and extent of harassment experienced by medical undergraduates during clinical training. We selected medical students from 4 batches of Rajarati University of Sri Lanka who have started clinical training. We determined to proceed our research as a qualitative study and to use volunteer self-selection as a sampling technique. We prepared a self-administered questionnaire as a Google form and distributed among these 4 batches through their batch representatives, and they assured that they posted in their WhatsApp groups that include all students of the relevant batches. During our data analysis, the method we used was thematic analysis. We noted down different types of harassment mentioned by respondents without any alteration. During data analysis process, repeated patterns could be identified. Then, we used them to generate themes. Majority among 69 valid responses stated they haven't experienced any form of harassment. 11 out of them mentioned that they faced harassment from medical officers, consultants, and other medical undergraduates. We asked participants to describe freely the incident which he or she has been harassed, their reaction following the incident, the impact of the incident on him or her, and their ideas and suggestions regarding the harassment. Types of harassments we identified during data analysis are verbal, physical, and mental harassment. Scolding, unnecessary jokes, name-calling, gossiping, considered under the verbal harassments. Having experienced the above types of harassments, the reactions they mention are wishing they could report the incident, sharing the incident with friends and parents, crying, avoiding the group that caused harassment. We could see the incident they faced has impacted on the responders in several ways. Negative impact on the mental well-being and academic activities, low self-esteem, reduced learning opportunities. The responders have several ideas and suggestions regarding the harassment. Contributing factors, gender and lack of clinical knowledge could be considered. Many refrain from taking any action against harassments as they perceived themselves being at the bottom of power hierarchy, need of a supporting mechanism. Finally, we have arrived into a conclusion. A significant proportion of the respondents have experienced harassment. Verbal harassment was the commonest form reported. Harassment caused a negative impact on students' mental well-being and academic activities. Need for a proper supporting mechanism was identified by the respondents. This makes the end of our presentation. The acknowledgement goes to the Faculty of the Community Medicine Department, the Faculty of Medicine and Allied Sciences of Rajarata University of Sri Lanka, the Dean, Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka, and all the participants who took part in our research. Thank you.
Now, the presentation is open for the discussion.
Hello. All right. Can you hear me? Right. Okay. Congratulations on completing your undergraduate research project and presenting it as a virtual poster presentation today. You have done a good job. So let me clarify certain things because there were certain discrepancies between your abstract and your poster presentation. Right. So just please, can you tell me why you chose a qualitative study to answer your research question?
Thank you for the question, madam. Actually, the research in this topic is limited around the world also. When going to the quantitative study, there should be qualitative studies. So we choose to do this research as a qualitative study.
Okay. So you have said that you administered a Google form to the clinical, those who have started their clinical appointments, right? So which batch in particular? Which year? Which year students? Huh?
From third year onwards, madam.
Okay. So what was the sample size?
Sample size, madam, we did not have an exact, we did not calculate an exact sample size because
Yes. Yes. What was the ultimate sample?
we got 700 students from all
Right. I see. Right. Okay. So, can you tell me what now you have stated in your abstract that the students stated that they have been harassed by the medical officers, consultants, and students. Were they the only groups of people you expected, or was that different from what you expected? Your hypothesis? What was the comment you can make over that?
Yes, madam, they were expected because these are the groups that medical students are interacting with. So we expected that they are going to be harassed, then it's from one of these groups. But there were only few categories that they mentioned only few. So we thought that they would have stated other groups as well, such as nursing officers and the other patients and bystanders, those people.
Okay. And so how did you get their negative? You have stated in the abstract that they experienced negative impact, therefore, on their academic activities and mental well-being. How did you retrieve that data? Just by the thematic analysis? So did you give open-ended questions for that, or how did you exactly get that.
Yes, madam. We allow the participant to respond as freely they are with their experience during clinical exposure. So we allow them to go through open-ended questions.
So so you said now it's only during the clinical exposure. Did you restrict yourselves to that
No.
part? No?
No, we mainly targeted the students with clinical exposure. So we expect their responses more related to the related their clinical trait.
Right, not dragging or anything. That was not included. Okay. So what are the recommendations that you can do based on your findings to the administration or to the student bodies, whatever the union or whatever? So what were the recommendations you made through this study? Findings.
After all, we could identify their ideas and suggestions they mentioned in Google form. Some of them they suggest it is better to have a supporting mechanism, reporting mechanism when they experience such type of harassment. Actually, we are having our mentoring sessions. So we hope as an intervention, we would like to strengthen these sessions more and interactive with the students and I think.
Okay, thank you and congratulations once more on completing your study. Good luck.
Thank you, madam.
Thank you very much, madam. Now we will move into our 10th presentation. The group members are Hettiarach ST, Gallage HGCJ, Gomes ND, Gunasekara WGC, Hasna MA, Herath HNPC.
Hello, I'm ST Hettiarach from Group 10, presenting our research on the topic Prevalence and Associated Factors of Depression among patients attending outpatient department in Teaching Hospital, Anuradhapura. Our other group members are HGCI Gallage, ND Gomes, WGC Gunasekara, MA Hasna, and HNPC Herath. Now let's move on to our poster presentation. Depression is the most common mental health disorder. However, only a few research studies have been published on the prevalence of depression in Sri Lanka. Even though numerous studies have been conducted to screen depression rather than conducting comprehensive diagnostic interviews, no published research has specifically investigated the prevalence and associated factors of depression in the OPD setup. In hospital setup, depression often goes unidentified due to lack of awareness, poor mental health literacy, and varied presentation of depression. Approximately 2/3 of patients with depression clinically present with somatic symptoms like changes in the appetite, lack of energy, sleep disturbances, and general body aches and pains. Depression can exacerbate existing illnesses, signs, and symptoms, and vice versa. However, it is a curable disorder that promotes a healthy existence. Our objective was to estimate the prevalence and associated factors of depression among patients attending the outpatient department in Teaching Hospital, Anuradhapura.
We have conducted a cross-sectional descriptive study among the patients attending outpatient department in Teaching Hospital Anuradhapura, and the patients was above 18 years of age. This excluded the patients with repeated visits during the study period, the patients who were severely ill or required emergency hospital admission, and patients with intellectual disability. Data was collected using a self-administered questionnaire that were developed to collect socio-demographic factors and to diagnose depression. A trained mental health doctor screened patients for depression using PHQ-9 and clinically diagnosed with depression based on ICD-10 diagnostic criteria. A total number of 300 individuals were recruited for the study. Out of that, 68.3% was female and 31.7% was male. Mean age was 47.37 years. Most of the patients were Sinhalese and the percentage was 90.7%. And also the most patients were married and the percentage was 82.7%. The overall prevalence of the study population was noted as 14.7%. And out of that, the prevalence of depression was higher among female, and it was denoted as 16.1%. The prevalence of depression among males were noted as 11.6%. As independent risk factors of our study population, history of mental illnesses, family history of mental illnesses, and ongoing psychological stresses and substance use was identified. Finally, we have concluded that the prevalence of clinical depression is high among the patients attending outpatient department in Teaching Hospital Anuradhapura. And it is important to raise awareness of depression and its varied presentation among doctors working in outpatient department for early diagnosis and treatment of depression. This is the end of our poster presentation, and have a nice day. Thank you.
Now, the presentation is open for the discussion.
Thank you for your presentation. Can you all hear me?
Yes.
Yeah, okay, right. So congratulations on your work. That's an interesting thing, some interesting work that you've done. Can I ask how did you select your sample? I mean, did you do a sample size calculation or based on what? How did you do your sampling? Can you explain that to me?
Thank you for the question, madam. We calculate the sample size from prevalence of depression taken from the previous research study, which is conducted by the National Hospital Sri Lanka in Colombo. Then, according to the prevalence, we calculate the sample size. Then it rounds off to the 300 participants.
Sorry, could you, what was the prevalence in that study?
It was 22%, around 22%.
So was that a hospital-based study or was it a community-based study?
Hospital-based study.
Right, and based on that, the sample size came as what?
Around 260. So we round off it to 300.
300, right. And how did you do your sampling for your study? What was your method?
Simple, randomized sampling.
Sorry?
Simple,
Again?
Simple, randomized sampling technique.
You use a simple random sampling technique. So can you tell me how you collected the sample? I mean, do you think it was really simple random sampling? How did you collect your sample? Someone? Anyone?
It's when we randomly collect the samples. Like we attend to the OPD setups, and before that we took permissions and we attend to the OPD in several days. Then we randomly go to the patients and took the informations and collecting.
Right. Okay. So you mentioned that there was a questionnaire and that you used a PHQ-9 and then the ICD-10. Now, can you tell me how, there seems to be a combination of a lot of things. How was that used to diagnose which of those or how many of those were used for diagnosing depression?
Actually, PHQ-9 was we selected for PHQ-9 is screening test. And
Sorry, a little louder.
PHQ-9 is screening test of our study. With more than 10, we suggest them into consultant psychiatrist and he diagnosed them under ICD-10 criteria.
Right. So who administered the PHQ-9? Self-administered or you all administered?
The self-administered questionnaire, we screen them.
You screen them. Right. Okay. And just one last question. Your odds ratios, you're showing odds ratios of less than 1. Yeah? Yes or no? Yes. Can you interpret those for me? And say it says a past history of mental illness was 0 point something something. How do you interpret that then? Does it increase risk or reduce risk, or how are you interpreting that?
There are increased risk of factors like we notice a significant, there is a significance in some factors like past history of mental illnesses and ongoing current stress. So basically, we got that significant according to the field.
Okay, right. Thank you. And well done. Good.
Thank you very much.
Thank you very much, madam. Now we will move on to Group 11 presentation. The group members are Jayasekara HADDS, Habaiba TH, Ilafi MTA, Imaya KPH, Jayapadma JHMYM, Jayasekara RMDT.
Esteemed panel of judges, organizers, and my dear colleagues, a very good day to all of you. I am RMDD Jayasekara from Group number 11. Our research title is Quality of Life of Women Diagnosed with Breast Cancer, a qualitative study in a tertiary care hospital in North Central Province of Sri Lanka. Currently, it is the month of October, and it is also the month of breast cancer awareness. The month is about more than pink ribbons. While some feel inspired, many living with breast cancer feel like the month overlooks their experience with the disease. Breast cancer is the second most common cancer among females worldwide. In Sri Lanka, it is the most prevalent cancer among females. And when we take a look at Anuradhapura, breast cancer is the first among all the cancer types prevalent in Anuradhapura district. Growth incidence rate being 10.4%. According to these data, 1 among every 10 women in Anuradhapura district is suffering from breast cancer. In a background like this, the objective of our study was to explore the quality of life of women diagnosed with breast cancer in a tertiary care hospital in North Central Province of Sri Lanka.
The study was a qualitative study with a phenomenological approach. After obtaining ethical clearance from the Ethics Review Committee, we conducted our study from November to December last year in oncology and oncosurgery wards of Teaching Hospital, Anuradhapura. The population targeted was women diagnosed with breast cancer with histopathological confirmation. 12 voluntary participants were selected by purposive sampling. Semi-structured, in-depth interviews were conducted with them, and interviews were transcribed verbatim. Then the data was analyzed using a thematic analysis method. After analyzing the data, we were able to identify 4 main domains and 13 themes. The 4 main domains are physical experiences, psychological experiences, socio-economic experiences, and spirituality. Under the domain of physical experiences, there are 2 themes: physical disturbances and appearance concerns. Physical disturbances included disease-related and treatment-related changes. Each and everyone was much concerned about appearance changes which were obvious due to treatment causes. In the domain of psychological experiences, perceptions on disease and treatment were mainly disbelief, anger, fear, and despair. Some have even mentioned that they had self-destructive notions like suicidal ideations in the past. They also had adhered to coping strategies, and some even mentioned their plans and wishes for future. When it comes to socio-economic experiences domain, intimate relationships was one of the key areas the participants were much worried about. Here, they had concerns regarding barriers for sexual satisfaction and marital issues owing to that. Their family roles as a mother and spouse were disrupted. Other themes in this domain were interpersonal relationships in clinical settings, social relationships, and financial strain. There were both positive and negative ideations on religion in the theme of ideation on religion in spirituality domain. The other theme here is existential issues. Following the analysis of the results, it can be concluded that the themes across the domains are inextricably interconnected. The patients do encounter a commendable cancer care where most of their needs are met. Yet, the realm of psychological experiences seems to be the most affected but least addressed area. A holistic approach is essential to address the multifaceted needs of breast cancer survivors. Psychological support and well-being should be prioritized and must be actively addressed by healthcare providers to effectively support breast cancer survivors. This remarks the end of our presentation. Thank you for your kind attention.
The presentation is open for the discussion.
Congratulations. It's a nice piece of work. So, first of all, I would like to know why you have preferred to go ahead with qualitative kind of approach rather than quantitative.
Thank you for that question, sir. We choose a qualitative study instead of quantitative study because of we wanted to identify in person the concern instead of giving a questionnaire. It limits only for a number of percentage their experiences which we already know. So we wanted to explore more concerns of them. So that is why we choose qualitative study instead of quantitative studies.
So, you have highlighted that the psychological aspect is the most concern and it is the least addressed kind of in conclusion. So, how you come to that conclusion that was least addressed because we just focused on the factors of it. So, any special reason why you mentioned that in the conclusion?
Thank you for that interesting question, sir. Actually, while interviewing our participants, so mainly what they mainly told was that, sir, because of the diagnosis following the diagnosis of their disease, to minimize the effects of the disease and to minimize the afterward things. So they have mainly focused on the treatment processes, which include the radiotherapy or like things and the surgical options. But the overall, the patients have stated that so they have experienced as much psychological disturbances, but because the prioritization is given to other things, the things were not attended in much aspect.
Right. So, given that your findings and several findings, you are highlighting that they are important to look after in this group of patients. And so I would like to know, after understanding what the things behind the scene, any special kind of interventions you would like to recommend for the healthcare staff in this kind of setting? Because based on your findings, what you are going to recommend, what you are going to tell the healthcare staff, you have to do this thing and you should not do that one, right? So likewise, any special kind of, what are your suggestions? What kind of interventions we can include to make their life better? Yeah.
Thank you for the question, sir.
Yeah.
Is the healthcare staff to train the healthcare staff on the psychological aspect, psychological part also, and we recommend the integration with psychiatric and oncology department on the treatment of the patients, and also some social work. We can talk to the social workers in the hospital about the patients and help them in the financial way and the psychological way. That's
Right. Thank you. Good.
Thank you very much, sir.
Thank you, sir. Let's move into our next presentation. Group number 12. The group members are Jayasinghe GK, Jayasundara JMKM, Jayatissa WMTP, Jayaveera KDTM, Jeevaratna PM, Khalid MM.
Hello everyone. In this session, we will be presenting you our research on the knowledge and attitudes regarding medically important snakes, snake bites, and first aid among first-year medical students of Sri Lanka. I am JMKM Jayasundara presenting this to you on behalf of our research team, GK Jayasinghe, WMTP Jayatissa, KDTM Jayaveera, PM Jeevaratna, MM Khalid. Moving on to the background, snake bites are a major public health problem in Sri Lanka. There is a total of 180 snakes species in Sri Lanka, which includes 93 land snakes and 15 sea snakes. Out of all these, all 15 sea snakes and 24 land snakes are venomous. Sri Lanka reports 398 snake bites per 100,000 population per year, which is one of the highest incident rates in the world. About 35,000 to 40,000 snake bite patients admit to government hospitals in Sri Lanka each year. Of that, many people develop severe envenoming, but less than 100 people die. These numbers can be higher than calculated values, as all snakebite patients are not admitted to hospitals or included in studies regarding snake bites. Farming communities like North Central Province records the most snake bites than any other region in the country, with an incidence rate of 623 snake bites per 100,000 population per year. Also, it shows that young and middle-aged farmers, mostly males, are commonly affected. Long-term complications of snake bites will lead to poor quality of life of the entire family, as most people who are affected by snake bites are the breadwinners of their families. Therefore, snake envenoming is a significant public health problem in Sri Lanka. Our aim in this project was to assess the knowledge of first-year medical students of Sri Lanka on general awareness of medical important snakes, snake bites, first aid, and attitudes regarding snake bites. Under the methodology, our study was a descriptive cross-sectional study. As our population, we took first-year medical students in Sri Lanka. The reason for choosing first-year medical students was their lack of exposure to parasitology curriculum, which is covered in the third year. Therefore, this population included participants that had knowledge of an average person in the community. And the study was conducted from December 2023 to January 2024. We used a self-administered questionnaire in the Google form as our study tool. The questionnaire included questions in Sinhala, Tamil, and English. The questionnaire had questions categorized into general knowledge, identification of venomous snakes, epidemiology, clinical effects, first aid, and attitudes on snakes and their bites, providing equal weight for all sections and questions, except for attitudes section, which consisted of 5 questions. We used Microsoft Excel as our data analysis tool. Moving on to the results, of 2,035 eligibles, 1,000 responses were received representing all districts and all medical faculties. We were able to find out that 24.3% of our respondents or one of their immediate family members had a previous snake bite. 37.4% of respondents had a farming background. Talking about the score of the questionnaire, most had accurately answered the majority of questions. Median score for entire questionnaire was 28 out of 43 with interquartile range of 23 to 29. Participants scored following marks for the subsections of the questionnaire. General knowledge, 4 out of 9 with an interquartile range of 2 to 5. Venomous snake identification, 7 out of 9 with an interquartile range of 5 to 8. Epidemiology, 3 out of 4 with an interquartile range of 2 to 3. Clinical effects, 7 out of 10 with an interquartile range of 6 to 8. And for recommended first aid, 7 out of 11 with an interquartile range of 6 to 9. Speaking about the knowledge regarding first aid, the participants had scored a good mark for this section with a median score of 7 out of 11. However, there were some concerning points like harmful first aid measures such as applying a tourniquet and incising the bite site were believed appropriately by 66.4% and 21.2% respectively. Moving on to the attitude section, 20% opined that seeking medical care for non-venomous snake bites is unnecessary. Further, 41.4% believed snake venom is not removed completely from the patient's body by allopathic treatment, and 43.8% believed seeking indigenous treatment after receiving allopathic treatment is beneficial for patients. 17% said that all snakes that come to their domestic environment should be killed. 66% thinks that snakes don't attack unless we cause harm to them. Finally, we came to the conclusion that participants' knowledge of snake bite is appreciable in general. However, the attitudes favoring harmful first aid practices suggest the need for educational programs in the community. We hope you find our presentation valuable. Thank you very much.
The presentation is open for the discussion.
Okay, thank you very much for a very timely as well as very important study and findings. And of course, it's very important in your area. Let me just ask a few questions. Like, can you please let me know why you selected this study population over the general population? Because students and not the general population to assess this question.
Madam, the first-year medical students are fresh from our general society. They are not exposed to parasitology curriculum yet. So we thought as a sample we can use them.
Okay. Okay. Now you said that your response rate was only almost 50%, right? 49%, I believe. So in that case, can you tell me the things that you could have done to improve the response rate? Because these are medical students, after all.
Well, madam, thank you for that question. What we did was we educated the first-year medical students of the importance of this matter, and that's the main thing we did. But unfortunately, 1,000 was the response rate we got, and we did not force them to participate in this research because that would introduce a bias like something like that. So what we could have done is we could have focused more on the importance of this research. Otherwise, forcing them to fill this out, I don't think that would be the best practice, and I think letting them know about the importance of the research is the best thing we could do.
Of course, this is unethical as well. But then, did you send reminders? Frequent reminders to them, reminding of filling the form?
Yes, madam, we have, yes.
Okay, great. Fine. So, can you also tell me now that you have found these findings? So, what are your recommendations to the VCs of these medical faculties in Sri Lanka?
Madam,
Can you please let someone else to answer? Sorry.
Our parasitology curriculum already is very good, but according to this general knowledge and this aid and attitudes, we can adjust our parasitology curriculum, and we can, as doctors, we should treat to patients. In teaching hospital Anuradhapura, there's prevalence of high of snake bites, so we should understand these things to treat patients also. So it's
Okay, I have several questions, but it's okay. Just one thing to improve your abstract. So when you're reporting the knowledge questions, the answers to the knowledge would have been better rather than giving us the median score if they had given proportions, so that we can understand apart, from the medical students, whoever had responded, how many had good knowledge and how many had bad knowledge or poor knowledge in respective areas. Okay, thank you so much and congratulations again.
Thank you.
Thank you, madam. The next presentation will be conducted by Group 13. Group members are Kalugalarachchi DN, Kaushalya ULCK, Kavindi NAS, Kalani Bandara KBBG PM, Obbagala KGSI, Kasturiyarachchi KAM, Veerakon HTW.
Good morning. Welcome to our research presentation conducted on knowledge, attitudes and practices regarding plastic water bottle usage among a cohort of Sri Lankan medical undergraduates. Plastic water bottles have become an indispensable part of life, providing convenience in portability and storage of water. 7 main types of plastics are used in water bottle manufacturing, and the type of plastic used is indicated by a number surrounded by universal recycling mark. The reusability of plastic bottles varies according to the material. For an example, polyethylene terephthalate or PET, indicated by number 1, is recommended for single use only. Prolonged and repeated use of the bottles made of PET increases the risk of contamination of drinking water with some bleached plastic and bacterial growth, which can result in adverse health outcomes. Bisphenol A or BPA is one such chemical currently under the study to assess its actual health outcomes. It accumulates in tissues and potentially harmful through different molecular mechanisms, and ongoing studies indicate potential harmful effects on cancer progression, reproductive and endocrine function. As it is not recommended to reuse single-use plastic bottles, assessing the knowledge and practices of using these bottles is important to identify possible measures that can be implemented to promote good health practices in the community. In this study, we assess the knowledge, attitudes and practices regarding plastic water bottle usage among medical undergraduates at Rajarata University of Sri Lanka. The study was conducted as a descriptive cross-sectional study. A structured questionnaire consisting of 31 pre-tested questions were distributed among the medical undergraduates using online platform. The questionnaire include questions to assess their knowledge on recycle codes of plastic, reusability of plastic water bottles, and adverse health effects of repeated use of single-use water bottles. Also, their practice of using plastic water bottles for daily use and storage of water was assessed, together with their attitude towards improving their knowledge and practice. In the data analysis, equal marks were allocated for each question under the knowledge and practice domains. After giving final mark out of 100, the level of knowledge and practice was categorized as good or poor, with 50 as the cutoff. Moving into the results, a total of 397 responded to our online questionnaire. Age range of the participants were between 21 to 27, while mean age was 24 years. Of them, 72% were female, and the highest response rate was obtained from the undergraduate academic year 18-19. The average score for knowledge was 47%, with only 45% having good knowledge of plastic bottle usage. The majority of those with the good knowledge were in the academic year 18-19. Also, we recognized a few knowledge deficit areas among the participants. 47.85% of the participants were not aware about the recycle codes of plastic bottles, and 49.62% were not aware about the single-use plastic bottles. 28.71% of the participants were not aware about the adverse effects of repeated use of single-use plastic bottles. Turning into practice, plastic bottles, the average score obtained by the practice was 40%, with only 42 of the study participants correctly using plastic water bottles. Of them, the majority were in the academic year 18-19. As a deficit in practice, 12.67% of the participants found to be having repeated use of single-use water bottles in daily use and 43.44% in the storage. We further analyzed the relationship between knowledge and practice of water bottle usage and identified a weak but a positive correlation between the two domains, indicating the importance of improving awareness about the correct usage of plastic bottles. More importantly, over 90% of our study participants expressed a willingness to learn about the possible health outcomes of repeated use of single-use water bottles, and they were keen on changing their incorrect practices. In conclusion, our research found that both the knowledge and practice of plastic water bottle usage were poor among the majority of the medical undergraduates. Planning and executing programs to improve their knowledge of plastic water bottle usage will not only facilitate correct practices but also will help to convey the correct knowledge to the community. At the end of the questionnaire, a knowledge resource was distributed. Thank you very much for your attention.
Now, the presentation is open for the discussion.
Okay, I'll start with the same question. So why did you use this study population? Why were you interested in this population?
Thank you, madam, for the question. So, madam, this in our faculty, we are forced to especially store drinking water with us, and majority of students use plastic water bottles for that, and that's why, madam, we use this population because this study is very relevant for.
Okay. So the response rate, so when you analyze the study participants, the majority were from your batch, is it? There was an academic year stated during the presentation, yeah? It's your colleagues that responded. Yeah, so what measures did you take to reduce the non-response rate during data collection?
The representative of each match and did a message to WhatsApp groups. And we have a Google form as well. And we inform and ask the students to respond to our Google form if they are willing, because we wanted was voluntary participation.
Okay, right. So there was this pie chart in your poster. There were pie charts in some others posters also, but you had a multi-component pie chart which reduces, the comprehensibility of the data presented. Can you suggest a better option to present that data rather than that pie chart with different components? You had a pie chart, right? At the middle of your poster, yeah? Yeah? And it had several pieces, unlike others two-pieced pie chart. Any other graph styles that you can use rather than a pie chart to present that data?
So I have 31 pre-tested questions, madam, and we get the total number of marks they gain out of the total number of questions, and we get it into 7 out of 7 marks, and we distribute it by a pie chart because it is more expressive, the data. We can also use bar charts and plotted charts and correlation charts as well.
So pie charts are more expressive, is it? That's new knowledge to me.
How much most of them didn't know about the plastic water bottle recycle codes, and we want to express it more pie chart.
A taller bar would not serve the purpose. Bar chart which would have a very tall bar and shorter bars. No? Okay, it's okay. Right. Okay, well done.
Thank you, madam. We will move on to the next presentation. Group members are Pulavasa RLPP, Lakmali DMP, Lakshane HAY, Liyanage SN, Madhavi PMUI, Madhubhashini PPU.
Good day to you all. Dear panel of judges, the organizers of the 6th Undergraduate Research Symposium, the Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka, and my dear colleagues. I am PPU Madhubani on behalf of the 14th Research Group. So, without further ado, let's dive into our research on multimorbidity among patients attending the outpatient department of the Teaching Hospital Anuradhapura. As we all know, the recent demographic transition has resulted in a transformation of morbidity profiles from communicable diseases to non-communicable diseases. There is also an increase in elderly population in Sri Lanka. So it is evident that more potential opportunities for health promotion and prevention of non-communicable diseases in primary healthcare services should be identified for more strategic health interventions in vulnerable populations. During our research, our objective was to describe the multimorbidity pattern among patients attending the outpatient department of the Teaching Hospital Anuradhapura. Multimorbidity is defined as the co-occurrence of 2 or more chronic illnesses in the same person at the same time. We have conducted a descriptive cross-sectional study in the outpatient department of the Teaching Hospital Anuradhapura. Our study population was the patients attending the outpatient department who were 20 years or more. We have used a systematic random sampling and a pre-tested interviewer-administered questionnaire. The following are our results. Out of the 362 selected patients, 32.9% or else 119 patients were found to be multimorbid. The median age of presenting to the outpatient department was 60 years, and we also have identified a female predominance. In the multimorbid patients, the following diseases were found to be the most prevalent. 60% of the multimorbid patients were found to be diagnosed with hypertension, 59% with dyslipidemia, 37% with diabetes mellitus, 25% with visual difficulties, and 22% with arthritis for a duration of 1 year or more. We have also identified a few other factors influencing the presence of multimorbidity in these patients. We have found an association with being educated up to grade 11, having an income level of between 20,000 to less than 50,000 rupees per month. We also have considered several other factors such as ethnicity, marital status, and employment background. But there was no association in these factors with multimorbidity. But we have identified a predominance of being Sinhala ethnicity, married status, and being unemployed in these multimorbid patients. We have also considered several other behavioral factors. 75.6% of the multimorbid patients were non-smokers, 89% were non-alcoholics, and 52.1% were involved in mild intensity range exercises per week only. So, in conclusion, multimorbidity was significant and observed among 1/3 of the outpatient attendees in our study setting. The majority were females. There was a correlation between education and the income level with the multimorbidity. So, based on these results, arranging further studies will be beneficial for better and quality primary healthcare services that are more patient-friendly and patient-oriented. This is the end of our presentation. Thank you so much for listening.
The presentation is open for the discussion.
Hello. Can you hear me? Right. Congratulations on completing your undergraduate research project and for presenting it at this virtual meeting. So I have grave concerns now because your abstract book gave an entirely different topic and an objective. And that was actually, if I read the title, Primary Care Utilization Among Patients Attending the Outpatient Department of Teaching Hospital, Anuradhapura. Your objectives, conclusion, everything was different. And what you presented here today is multimorbidity among these primary care attendees. How come? Ms. Madhavi, are you there? Yes, you have an explanation because I am thoroughly confused. Even in the last presentation of mine, there were small discrepancies, but here I mean, it's okay to upgrade, but this is entirely different. What's the, you submitted the wrong thing for your...
No, madam. Thank you for the question, madam. During our research, when we do the data collection, also we consider the care utilization also. However, we prepared separate abstract, means that three abstract. It is based on mainly multimorbidity, which is today presenting. We are presenting, and also separate one for utilization, healthcare utilization, and the healthcare utilization. However, we presented the
Wrong one.
no, madam. We presented the results of the healthcare utilization to the Anuradhapura Research Clinical Society Research Symposium. So here we mainly
But the abstract you have submitted is primary care utilization, right? So anyways, now whatever I'm going to question you on what you presented today, okay, because I was rather confused going back with I have read the wrong abstract or something. So that is, I don't know what has happened. So anyways, can you tell me what are the, right now, I have prepared myself for the other abstract, but can you tell me maybe, Professor Nuwan, maybe you can give me a few minutes more because of this situation. So can you just tell me what are the conclusions you came up with under your the objective you presented just now? What are the conclusions you arrived, and how can you make recommendations based on that? Because how did you define multimorbidity?
Thank you for your question, madam. We define multimorbidity as the co-occurrence of 2 or more chronic illnesses in the same person at the same time for more than 1 year duration, for 1 year or more duration. Our conclusions are we identified a female predominance, and multimorbidity was present in around 33% of the in our population, and there was an association of multimorbidity with being educated up to grade 11 and having an income level between 20,000 to less than 50,000 rupees per month.
So can you tell me, now you presented certain percentages like hypertensive patients, this percentage, eye diseases, this percentage likewise. So how, what, I mean, is it the same person having? No, I mean, it is just the prevalence or percentages among your sample, right? So there was no multimorbidity. I mean, then it should be 2 diseases existing together or 3, or, you know, like metabolic syndrome or something like that. So again, can you explain how did you come up? I mean, a person, the percentage of people presenting with hypertension and diabetes, hypertension and obesity, I don't know. How did you categorize like that? Eye diseases and other non-communicable diseases, whatever?
This is just the percentage of overall presence of multimorbidity, overall presence of diseases in multimorbid patients. We haven't categorized.
How did you identify with the, I mean, what was the eligibility criteria?
Thank you.
To distinguish between, yeah?
Madam, we selected all the patients that attended the outpatient department of the teaching hospital Anuradhapura, and based on the registry that they have registered, we considered only the registered patients at the OPD department. And also we selected patients who were 20 years or above, excluding any emergency or patient, any patient that is less than 20 years of age.
Right. So based on this thing, if you're given another chance to improve your study, what are the aspects that you will reconsider changing and doing?
Thank you for the question, madam. We take the data collect from the teaching hospital Anuradhapura primary care from 8 a.m. morning and the evening 6 p.m. So at that time, mostly the presenting patients are female predominance, unemployed ones. So here we mainly consider, so in results, mainly that's why female predominance, female predominance is the result. So however, we have to consider the male male persons and the male person and
Right. Anyway, thank you. And one small advice for you when you are submitting your research abstract for your exam purposes or whatever, I mean, we need a holistic understanding of what you have done. So better without salaming, cutting and presenting it at different conferences, one piece at a time. I would advise you to give the full abstract to the department for this purpose, basically, right? Because that would be, I'm sure, that must be the objective of your research project, first and foremost, right? Then you can submit to whatever the conferences you want, but for this, we need the full abstract, right? I'm pretty sure your teachers will also advise you on the same grounds. Okay, good luck. Congratulations.
Thank you very much, madam. Let's move on to the 15th presentation. The group members are Madhushani HKK, Madhushani HKDA, Madhushani LHK, Madhuvanti MAN, Mallavarachi GN, Manamperi MMKA.
A very good day to you all, the panel of judges and the organizers of 6th Undergraduate Research Symposium, Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka 2024, and my dear colleagues. I am Nimasha Madhuvanti. I am on behalf of Research Group 15 and I would like to thank you all for giving us this opportunity to present our research on alterations in oral soft tissues, teeth, and microbiota among betel quid chewers versus non-betel quid chewers. Betel quid chewing is a traditional practice prevalent in Asia, including Sri Lanka. But there are less number of studies are found to be done in the literature in Sri Lanka. So, betel quid chewing is known to have deleterious effects on oral soft tissues, including leukonoids, and also on oral hard tissues, including gum bleeding and discolorations, and as well as there are effects on teeth, including dental caries and periodontal diseases. So our aim is to support for the identification and prevention of changes in the oral soft tissues, teeth, and microbe that precipitate the risk of oral cancers. Our objective in this research is to describe the changes in oral mucosa, teeth, and oral microbiota in betel quid chewers and non-betel quid chewers. So here we have used a cross-sectional comparative study design, and we have chosen as a study population in people who are living or working in Salipur area and Anuradhapura, and we have included people between age 18 and 80. So we have excluded people who are unable to give oral samples. We have selected a total 82 sample size, including 41 betel quid chewers and 41 non-betel quid chewers. So the data collection was done using an interviewer-administered questionnaire and a dental severity index. So we have done a laboratory-based study conducted in the research laboratory, the Department of Microbiology, Faculty of Medicine and Allied Sciences, Rajarani University of Sri Lanka. We have examined the macroscopic and microscopic changes in those oral samples. So the data analysis was done using a SPSS statistical software beta version using chi-square and man-Whitney test. We have assumed the p-value is less than 0.05 is significantly statistical difference. The ethical approval was given by Ethics Review Committee, Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. So moving on to the results, we have found the majority of the betel quid chewers were males and the majority of non-betel quid chewers were females. When talking about oral mucosal changes, we have found there is a significant changes in oral mucosa like leukoplakia, atrophy, pseudomembrane, erythema, hyperkeratosis, and leukonoids in betel quid chewers. So the percentage of at least a presence of one of the oral mucosal changes that I have mentioned before in betel quid chewers is 29.26% and in non-betel quid chewers it was 7.31%. So it is statistically significantly different as the p-value is 0.01. When moving on to dental hygiene comparison, mean values of dental severity index, it shows that in betel quid chewers it was 57.85% and also in non-betel quid chewers it was 25.15%. So there is a statistically significant difference as the p-value is less than 0.001. So moving on to oral microbiota, we have found there are no statistically significant difference in bacterial colony counts between betel quid chewers and non-betel quid chewers groups as the p-value is 0.33. So we have mainly identified organisms are gram-negative cocci, gram-positive cocci, and gram-negative bacilli in both betel quid chewers and non-betel quid chewers. So in lactophenol cotton blue staining, we have mainly identified Candida and Aspergillus species in both betel quid chewers and non-betel quid chewer samples. So when coming into the conclusion, there is a significant association between betel quid chewing with oral mucosal changes as well as the dental hygiene. But there is no significant association between betel quid chewing with quantity of oral bacterial population. Here comes the end of our presentation. Thank you very much.
The presentation is open for the discussion. Right. Thank you for your presentation. That's an interesting work. Can you tell me what you think are the limitations of your work?
Thank you for the question, madam. There were several limitations in our study. There are now previously conducted studies using quantitative method to assess oral changes within betel quid chewers. So we have to initially found correct dilution methods using several dilution series. And after found the correct dilution methods, we have to discard previous samples. Also,
So, wait, are you talking about the oral wash sample?
Yes.
You're talking about the wash sample. Now, what did you collect the wash in? What was the wash? The liquid, what did you use? Sorry? Distilled water. Yeah. And how did you instruct the patient to collect it?
we told the patient to don't take any food 1 hour before the sample collection. Then we 10 ml distilled water give to the people, and then we rising the oral ocean, then collect to the sterile bottle.
Into sterile bottle. Right. And then how did you transport it back to the lab?
Transport to the via using ice as soon as possible to the lab.
And what were the kind of cultures that were done?
We done the SDA culture for fungal study and blood agar for bacterial culture.
Right. So do you think that after taking a distilled water wash and just a distilled water wash, then doing subrod culture and a blood agar culture, that you can comment on oral microbiota? Sorry?
Actually, madam, as this is a non-funding undergraduate research, we have limited resources. So, according to our affordability and available resources, we had to limit our research for the available resource. So, as there is alteration in the growth, we couldn't identify the significant difference actually.
Right. No, that's fine. Your limitation in funding and all, I understand. You need to be careful about whether you can then conclude to say microbiota. Okay. One last question. Were your beetle chewing and non-chewing populations matched? Your beetle chewers and the non-chewers, your two groups, were they matched?
They are random samples, madam.
Right. So in terms of age, gender, etc., were they the same?
No.
Not really.
No, madam. Only the count, there are 41 beetle chewers and 41 non-beetle chewers. There is no gender or age significance in the sample.
We choose 18 and 80, madam. That is the only match, madam.
Okay. Okay. Thank you. Good.
Thank you, madam.
Thank you very much, madam. Now, we have completed all 15 presentations in the morning session. I would like to invite Professor Nuwan Wickramasinghe to discuss the overall feedback by the expert panel.
Right, thank you very much. Thank you very much once again for the panel of evaluators. As I mentioned in the morning, we really appreciate spending time, almost 3.5 hours with us, despite your busy schedules. As I told you, some of you were busy with examinations, some of you were busy with meetings and academic teaching and other endeavors. But despite that, thank you very much for spending time with us. And finally, I don't take much time. Finally, 1 or 2 overall comments we would like to hear from you to improve the quality of research of these undergraduate students with regard to their poster presentations, the way of presentation, as well as how they have answered the questions. And at the same time, I would like to apologize for the discrepancy that one group has done in relation to the abstract submitted and the poster presentation. So I would like to start with Dr. Damitha.
Thank you, Professor Nuwan. Actually, overall, I think all the students have performed really well. So I'm sure they have learned a lot. So I would like to highlight 3 main things. One thing, whatever the research they do, I think they have to understand that the most important part is the method. If it is not scientific, no point of talking about the findings and the other stuff. So methods is the most important thing. So they have to, as students, you all need to focus on that aspect first before you proceed with any research, any kind of a study. And secondly, whatever the research you do, at the end, there are limitations. So I don't think anyone can come up with a study which does not have any limitations. So the most important thing is you need to identify and you need to acknowledge the limitations you do have in your research. So that is the second point I want to highlight. And the thirdly, actually, there are so many places that you can improve. So this is the first experience that as undergraduates, this is the first experience you are having, and you have gone through this kind of a research project. But the most important thing is that there are so many things you have learned during this period and during this module. So you can build on those skills, and definitely, whatever the field you decided to move on as a medical profession, you need to have very sound research understanding and the knowledge and the skill. So I would like to congratulate all the students who put their hard work behind this project and this symposium, as well as the community medicine department staff, as well as the other staff members who are supervised and contribute to this thing. So it's a really, I'm really happy about the outcome. So congratulations to all. Thank you.
Thank you very much, Dr. Damitha. And we have Dr. Ishanka Talagala as well. Dr. Ishanka, if you are here with us, yes.
Yes. Thank you so much for the opportunity given, Professor Wickramasinghe. And in addition to that, I would really like to congratulate, I think, as you said, this is the 4th time, and I think I've been joining with you all for 3 years, I believe. So I'm really happy. And as usual, you have done a good job, and congratulations to the community medicine department and your entire team, who must have worked tirelessly to get such an organized thing, because it's not easy, we all know. But again, just to a little point to improve, I believe it's better that at least the community medicine department could go through the abstracts that they have submitted. That would have been better, so that we can improve the quality of the abstracts. As Dr. Damitha very correctly told earlier, the methodology, the methods were not proper. Of course, they have spent a lot of time and effort on reporting results, and but the methods were not properly reported. So I think it's better that you all go through the abstracts, because I think compared to the last years, that is a lapse that I have seen, and there were many grammatical errors, there were many mishaps, the conclusions were not with the results, and the objective was different. Because, and again with the presentations also, I saw that the conclusion of the abstract is completely different from the conclusions of the presentation, and of course, as we all saw, one abstract was, one presentation was completely different. So I think it's better that if possible, and if you have enough resources, please go through it so that we can improve the standard and maintain the standards that you all had as well. So thank you so much again for the opportunity, and very well done. Good job. Thanks.
Thank you very much, Dr. Ishanka. And we have Dr. Manuja Pereira as well. Dr. Manuja.
Yeah, Prof. Nohan, thank you for inviting me. I enjoyed this a lot because there were many groups who have done well, and there were very interesting topics as well. And I hope by participating for this symposium and seeing others, how they have presented their results, how they are presenting, how they are delivering their findings, they have learned a lot too. I also agree that the methods was not adequately reported in many abstracts, and they were not reported in the poster as well. I guess it's the students, they have probably taken it lightly maybe, and they were concentrating more on their results, which they felt important. So the methods, all of them have to understand the importance of methods. And I also need to give some advice about the use of terminology, like, because they engage in this research, they are supposed to read around the topics and everything. For example, there was one topic using the word substance abuse. which is an outdated term, even though it is commonly used still, even in some UN organization documents. It's always, as public health professionals, as ComMed specialists, we go for substance use because that's the one that produces harm to health, social, and economy aspects. So, and someone was talking about vaporizers, vaporizers can mean anything. So, better to be, what do you call it? Be vigilant about the terms used and learn to use the correct terms as well. So I would finally like to congratulate all of them and for the job well done to the department as well. Thank you.
Thank you, Dr. Manuja. And we have Dr. Samini Navaratna as well. Dr. Samini.
Thank you, Professor Nuwan. Well, it was, as always, it was a pleasure to join with all of you. And I think you all have done a marvelous job in organizing. I was even telling Dr. Damita about the positive aspects of this type of virtual thing rather than, all the what we are doing, a lot of resources. I think sometimes I'm rethinking whether we should also adopt something like this. But I don't know whether we will be allowed to do that because of the constraints from the reviewers and all these things, institutional reviews and things. But I think you all have done quite a marvelous job, and most of the students are also, well groomed, very pleasant, and they did a good job. And I must congratulate the team behind this because I know what a lot of effort and what a lot of resources are spent on such a throughout the undergraduate projects. I mean, it spans through like 2 years. So most of the things, the supervisors, the examiners, and I mean, getting together everything, getting ethics approval and all these milestones. So it's just, this is just the output, but then a lot of effort put together by the whole team. I'm sure you all have done a very effortless job. However, I want to congratulate you. I think I have been coming to these sessions from the inception itself. So congratulations once again. And I agree with all the things the other examiner stated. So I actually advise the students during the examination also, so I'm not going to go there again. So congratulations and good luck for the future endeavors.
Thank you very much, Dr. Samini. And we do have Professor Champaratna Tunga as well. Ms. Champa.
Thanks very much, Prof. Nuwan. I mean, thanks for having me. And as everyone said, I mean, congratulations on fabulous organization. I mean, we really appreciate the precision of your organization. I mean, really, if you train students to your level, I mean, the way you all organize things, I don't think they'll have anything to worry. And I'm the only things that I would have to say is it's pretty much exactly what everybody has said. I would, encourage, because they tend to use language that I'm not sure they understand. So I think they're reading off, they're speaking quite fluently, but I think some of the technical terms and some of the statistical terms and tests and things that they're saying, I don't think they really understand what they're saying. So it might be better at their level if they say something simple that they can understand. And make sure that it comes from comprehension rather than trying to sound good. Then also even in the abstract, but also in the presentations, for them to look into precision of reporting. That should this be reported as a number? Should this be a percentage? If it's a percentage, how do I make sure people know it's a percentage of what? If this is a test, then how do I indicate the test that has been used? Should this be, what kind of, so the precision of reporting that, how do you train them to make sure that that is seen? And that, as Namita said, that, limitations, the ability to see limitations is probably the best thing that they can achieve. and not to be worried about that. That if they can see that, so those are the things that I would highlight for them. They seem to want to show a perfect picture, which is nobody gets to do that. So that to take that mentality away from them, that being able to say something simply and then say these are the problems and this is the issue, that is a better approach to things, that would be what I say. But congratulations overall. The variety of things that they had gone into and the variety of ways they presented was absolutely fascinating. So congratulations.
Thank you very much once again for all of you for being with us today for this particular event, and more than that, for your constructive criticism on the scientific rigor as well as the scientific reasoning and also the better interpretation of results. These are the things that our buddy researchers would learn from. And as I mentioned earlier, this most of them, this is the first research that they have done. So this is a very good stepping stone for them. One little comment that I would like to make at the end, because with regard to scientific rigor and everything, we do have a procedure by which we go through their research proposals, and they are supposed to obtain the ethical clearance, under which not only the ethical aspects, but also the scientific methodological aspects are being commented. However, as we all understand, because of certain limitations and constraints, sometimes there are deviations in relation to the way that they conduct. However, that does not mean that they can present something which is substandard. And the abstract submission as well as poster presentation, basically it's up to them to do the submissions in relation to the abstract that they have presented in the abstract book. And all these things is part of the learning curve. That is why in our evaluation form, we have allocated marks for the abstract as well as the presentation in relation to the scientific methodology that they have presented, as well as the meaningful integration of results. So thank you very much once again. And we hope in the future also you will help us to evaluate abstracts in our undergraduate research symposia. Thank you very much.
Good. Thank you.
Thank you very much. We hope our undergraduates had constructive feedback and discussions to thrive as young researchers in future. To conclude the morning session, I invite Dr. Ayash Hettiarachchi to deliver the vote of thanks.
Ladies and gentlemen, thank you for giving me the opportunity to propose the vote of thanks for this special event at Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. On behalf of the organizing committee from the Department of Community Medicine, I would like to extend my gratitude to our expert panel of evaluators, Dr. Damitha Gunawardana, Dr. Ishanka Talagala, Dr. Manuja Pereira, Dr. Samidhi Navaratna, Professor Champa Ranatunga. Thank you for taking the time to share your expertise with us despite your busy schedules and for judging these student presentations. Next, I would like to thank Dean of Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. Sir, we truly appreciate your continuous support throughout the module activities and your invaluable help in making this event a success. The true strength behind the success of these students lies in the dedication of their supervisors. So, I would like to extend my heartfelt thanks to all academic staff members of Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka, who guided these student groups and contributed in numerous ways to success of this event. I must also thank the extended faculty of the Faculty of Medicine and Allied Sciences. A special thanks goes to Senior Assistant Registrar and all the non-academic staff members of Faculty of Medicine and Allied Sciences. My sincere thanks to Mrs. Achini Irukal Bandara and her team for their excellent support with the IT aspect of the symposium. A heartfelt thanks goes to Professor Sunet Agampodi and Professor Tilini Agampodi for being our pillars of guidance. I would also like to extend many thanks to Professor Nuwan Wickramasinghe and Dr. Janith Warnasekara for their deep commitment to successfully completion of this Research in Medicine module. A very special thanks goes to temporary lecturers and other academic staff support members of Department of Community Medicine, Dr. Sahan, Dr. Prasadika, Ms. Manojika, Dr. Ravinya, Dr. Jalia, Dr. Hirunika, Dr. Pasindu, Dr. Ishan, Ms. Sonali, Mr. Dilan, Mr. Kavinda and Ms. Krishanti for their hard work in organizing all the logistics of this event. Dear students, On behalf of the organizing committee and the Department of Community Medicine, I thank you for your active participation. We wish you all the best in your future endeavors, and we hope that even though you completed this research in medicine module, you will continue to engage in research. Thank you very much and have a wonderful day.
Thank you, sir. We will meet with the afternoon session at 1 o'clock. Thank you very much.
Recording stopped.